In a previous set of PowerPoints, we talked about the development of cancer, and now we're going to talk about some specific exemplars related to cellular regulation problems. The objectives for this set of PowerPoints will be these. The learner will be able to discuss the risk factors for various cancers, specifically breast, lung, colorectal, non-Hodgkin's lymphoma, and lymphocytic leukemia. The learner will be able to identify proper assessment necessary for each. The learner will understand cancer progression in each of the exemplars listed in objective number 1. Learner will have an understanding of possible treatment plans and develop a proper nursing plan of care for each. The learner will know the teaching that is necessary for prevention of and treatment for each listed. Before we talk about breast cancer, I'd first like to discuss the benign tumors that are possible. The first and most common benign tumor in women during their reproductive years is what's called fibroadenoma. This is a mass of connective tissue that's unattached to the surrounding breast tissue. And the unattached is important because what that means is this particular tumor will be movable. It won't be stuck, it'll be mobile. It's usually discovered by the woman herself or during mammography. The cancer risk from a fibroadenoma is very small. The tumors are oval, as I said, freely mobile, and rubbery feeling. And they range anywhere from 1 centimeter to 15 centimeters in size. They may occur anywhere in the breast, and a breast ultrasound or needle aspiration is done to determine if it is cystic, which is fluid, or solid. If it's solid, an excision under local anesthetic is done, and that will be biopsied to rule out cancer. The second most common cystic cancer is fibrocystic breast condition. This may involve the lobules, ducts, and stromal tissues of the breast, and it most often occurs in premenopausal women ages 20 to 50. The typical symptoms are breast pain or tenderness, tender lumps, and swelling. They occur prior to the menses and usually resolve after the menses is over. The two main features of fibrocystic breasts are fibrosis and they are cysts. Postmenopausal women taking hormone replacement therapy to deal with menopausal symptoms may develop fibrocystic breast condition or have an increase in the symptoms if they had it before menopause. There is no increase in breast cancer risk in someone with fibrocystic breast condition. A biopsy would be done if no fluid is aspirated, if the mammogram indicates suspicious findings, if the mass remains palpable after it's aspirated, and if the aspirated fluid reveals cancer cells. Now moving into the malignant forms of breast tumors. Breast cancer is second most common cancer in women. Skin cancer is the first most common cancer in women. It is the second most common cause of female cancer deaths, with lung cancer being the #1 cause of female cancer deaths. Early detection is key to effective treatment and survival. The 5-year survival rate for localized breast cancer is 98.6%. So you can see that early detection, pretty much you're going to be okay. For cancer that has metastasized to lymph nodes, however, it does decrease down to 83.8%. The survival rate drops dramatically when it becomes metastatic, when it's gone beyond those lymph nodes and has now gotten into the bloodstream or into the lymphatic channels. Some of these breast cancers are palpable, others only show up on mammogram, and there are 2 types of breast cancer. There's non-invasive and invasive. Metastasis occurs via the blood and lymph systems, which permits the spread to very distant sites. Specifically, the most common ones would be bone, lung, brain, and liver. Non-invasive breast cancer consists of two primary ones, the ductal carcinoma in situ, which is abbreviated DCIS. It's an early non-invasive form of cancer. It is, if caught early, it hasn't gone anywhere but within the ducts. They're located within the duct and they have not invaded the surrounding breast fatty tissue. Very high survival rate if it's caught that early, but if it's not treated, 14 to 53% of them will become invasive. The lobular carcinoma in situ, which is LCIS, is rare. It's located in the lobules of the breast, and that's basically where the milk is produced. It's not a true cancer, but it does increase the risk of cancer in the future. And some women may consider prophylactic treatment with tamoxifen, raloxifene, or even doing a mastectomy. Invasive cancers, the infiltrating ductal cancer is the most common. It originates in ducts and grows in the epithelial cells lining these ducts. Once it's invasive, it grows in the tissue around it in an irregular pattern. That's real important to realize that tumors that are cancerous will not have a well-defined, nice circular shape. They are irregular. They are poorly defined. You can't really feel any defined edges to them, and they're fixed. They're stuck. They're not mobile at all. They're adhering to the chest wall. Eventually, fibrosis will occur, which is made of connective tissue and collagen, and that gives the dimpling effect that we teach women to look for. Late-stage breast cancer becomes edematous thickening and pitting of breast skin or orange peel skin, which you see as a picture in the picture here. Another rare but highly aggressive type of invasive breast cancer is inflammatory breast cancer. The symptoms of this would be swelling, skin redness, pain. It seldom presents as a palpable lump and may not show up on mammograms, so you can see how it would be very difficult to diagnose this early. And so it's generally diagnosed at a later stage and therefore much harder to treat successfully. Breast cancer does occur in men. It's rare. Fewer than 1% of all breast cancer cases are in males. The average age of onset would be 68. And the symptoms for guys is usually a hard, painless subareolar mass. Gynecomastia may be present, where men have the enlarged breasts. Nipple discharge, retraction, erosion, or ulceration may be present. The diagnosis for men is usually delayed because they're not suspicious of it. It's just a lump, and they don't realize it's something to be concerned about. Treatment for breast cancer in men is the same as for female breast cancer. Breast cancer in young women account for about 4.6% of breast cancer cases in women under 40 years of age. There is a genetic predisposition as a strong risk factor for the younger women getting breast cancer, more so in the younger than in the older women. They frequently present with the more aggressive forms of the disease, and the number of cases is increasing. The screening tools are less effective due to the younger women, their breasts are more dense, and so mammogram screening is not really even recommended because it cannot detect breast cancer in dense breasts. Special unique issues to be considered when you're taking care of a young woman who's dealing with breast cancer is her fear of surgical menopause, because the treatment for that will often induce a menopausal state. They may become infertile after treatment, and they may have sexual dysfunction. And then just think of all the self-esteem issues as the woman has to deal with perhaps losing a breast, or at least the risk. Regarding the etiology and genetic risk factor for developing breast cancer, there is no single known cause. Being an older woman or a man is the primary risk factor. Some risk factors are modifiable, others are not. Having several risk factors will increase the overall risk. Some of the behaviors that can be modified would be the weight. Yeah, they make that sound easy. Older women losing weight, challenging, but it can be done. So avoid weight gain and obesity. Engage in physical activity. Become more, walking every day, at least something every day. Minimize alcohol intake, but that is a risk factor. So the more you drink, the more at risk you are. Previous oral contraceptive pill use will put you at an increased risk for breast cancer. And breastfeeding reduces the risk, as does the avoidance of hormone replacement therapy. The American Cancer Society has reports that there were 232,340 cases of breast cancer in 2013. And as I mentioned, it's the second leading cause of cancer death. Lung cancer is number 1. Let's talk about health promotion and maintenance. It's recommended that screening mammograms be done yearly for women over 40. A clinician breast exam should be done every 3 years, ages 20 to 40, and then every year after that. Monthly breast self-exam is less emphasized today, and I've put question marks there because I'm very confused by this. Most breast cancers are found by the woman doing a breast exam on herself. That's going to bring most women in. So I'm just a little confused with that. It's free, doesn't cost anything. Let's just do it, right? Let's teach women to do a monthly breast exam. Women with genetic mutations or high risk factors would also have an MRI, and a breast ultrasound sometimes is used when problems are found on the mammogram. What teaching needs to be done? The breast self-exam, and this is where I got confused as I kept reading, and it says, become familiar with the appearance and feel of their breast. Well, that's going to require them to do a breast exam if they're going to become familiar with the appearance and feel of their breast. So yes, we still do them, and breast exams should be done after the period is over, because as I mentioned in the fibrocystic and fibroadenoma section, we can get lumpy before our periods. So someone calling in saying she's found a breast mass, the first question I'd ask is, when is your period due? And if it's due the next day or two, I'm going to tell her, wait till the period's over, recheck. If there's a lump is still there, come on in. If it's not still there, it's just a cyst. So they need to be taught to do it after the period's over. Now, women who are postmenopausal, we just have them do it the first of the month, because they don't have periods, so just the first of the month. Lumps are not necessarily abnormal. Women should be taught to not delay the follow-up. If you find something, don't be so afraid that it's cancer that you don't come in and get proper follow-up. We usually will reassure them that they are okay. But even if they're not okay, the earlier cancer is found, the better the survival rate is. And as I've mentioned, discuss the proper timing of breast self-exam, which is post-menses. Proactive actions some women, some high-risk women might take will be talked about next. Women who test positive for the BRCA1 or BRCA2 gene mutation who have a strong family history or other high-risk factors need very close surveillance. And that phrase means to get annual mammograms, an annual clinician breast exam, an annual breast MRI, which will detect things more that are not seen on a normal simple mammogram. Some women may choose the prophylactic mastectomy or oophorectomy, removing the ovaries. There is still a small risk of cancer in the residual breast glandular tissue if they do choose to have a mastectomy, so they need to be properly instructed on that. An oophorectomy will cause them to go through early menopause. So they need to be made aware that that's going to happen, and we would not encourage them to be on estrogen because of the risk of hormonal-fed cancers. Anti-estrogen drugs may be given, but those carry the risk of blood clots and endometrial cancer. So lots of pros and cons and things to weigh when making these decisions. How do we assess? What's the type of assessment done to determine the breast cancer presence and how bad it is? A history of breast mass or lump will reveal information about the course of the disease as well as the patient's personal health care seeking practices and health promoting behaviors. As I mentioned just a bit ago, if they find a lump, how quickly do they get in? I mean, are they going to come in to get follow-up soon, or are they afraid and delay follow-up care? When they're in, ask how, when, by whom was the mass discovered, and how long between discovery and seeking care has it been? Any other changes in their body over the past year? Use of alcohol intake? Do a psychosocial assessment. Who do they know that's had cancers, and specifically breast cancer? What happened to that person? What are the presenting beliefs about breast cancer just from their own experience with friends or family members? Or have they had breast cancer in the past and this is reoccurrence? What is their partner's involvement in this? Are they supportive? What is the relationship like? Is it a strong relationship, or is it going to be real rocky? Lots of things to assess in these women. The laboratory assessment would involve basically the pathology exams, to sending tissue to pathology for determination. Imaging, as I've mentioned, the mammogram, ultrasound, MRI. A breast biopsy is the only definitive way to diagnose cancer. It is classified according to the size and type of breast cancer, the histologic grade, and the type of receptors on the cells. All this guides the treatment. The NANDA diagnosis, the first one, is ineffective coping related to unanticipated breast cancer diagnosis. Assess and help develop coping strategies. Learn who their support person is. Do they have a close family relationship? Do the family live nearby? Basically what support does the person have? As I've mentioned before, assess the previous experiences with cancer in herself or in others, and assess the patient's need for knowledge. Some will want to know right away a lot of things, that others have to mentally digest this new diagnosis for a few days before their mind is ready to think about anything more. So that needs to be assessed. The second NANDA diagnosis would be potential for metastasis of the cancer. We want to prevent that. So there's different methods to help reduce that risk. There's the non-surgical treatment, which consists of radiation, chemo, hormone therapy, or targeted treatment with radiation. Some women, 80% of women choose to do complementary and alternative medicine techniques or treatments. Some that they do would be vitamins, special cancer diets, herbal treatment, prayer is big. These women should consult with treating physician prior to starting any of the complementary and alternative medicine techniques that involve diets or vitamins or herbs, because of the risk of interference with their prescribed treatment. Breastcancer.org is a great site to provide help and information about these complementary alternative medicine therapy. Surgical management will most likely happen with breast cancer. If there's a mass, it needs to be removed, pure and simple. Get it out of there. But first, it may go through a chemo treatment. Large tumors might first be, to reduce the size, be subjected to chemo to try to get the tumor to be as small as it possibly can be prior to the surgery. And this is known as neoadjuvant treatment or therapy. Axillary lymph nodes would be analyzed to make sure those are not, cancer in them. Sentinel lymph node biopsy would be done, and I encourage you to look on figure 70-5, which is on page 1473. It shows great three pictures of how they do that. But basically, if the sentinel lymph node is negative, then we know cancer has not spread beyond them. It's limited to just the tumor itself, so it's more local, hasn't gone out yet. Some patients may choose to do breast conserving surgery, which would be a simple lumpectomy. Of course, this all depends on the size, the location, and the patient's desires. Some choose a partial mastectomy, just take the part of the breast that where the tumor is and make sure you get the margins out. The margins is the distance between the tumor and the edge of the surrounding tissue, and the goal is to have negative margins. Radiation treatment will usually follow. I had a burp, I'm not drinking. So radiation therapy will usually follow that as well. Mastectomy remains a popular option as a prophylactic treatment. Just some women will many women will just say, I just get it out of there. I don't want to even worry about it. The indications, especially for mastectomy, would be a multicentric disease. In other words, the tumor is not local into one area. It's in various quadrants of the breast. If they have an inability to have a radiation therapy for whatever reason, if there's a large tumor in a small breast, that woman may decide just take the whole thing. Don't try to preserve a small breast. And again, patient preference. They just want to remove the breast and minimize their future worry. A total or simple mastectomy will remove the whole breast. A modified radical mastectomy removes the breast tissue, lymph nodes, and underlying chest wall muscle. These patients will have 1 or 2 drainage tubes when they come out of surgery called Jackson-Pratt drains. Keep it from fluid from filling up. The teaching needs for these patients, these women pre-op, would be psychological preparation. Sometimes even having a woman who's been through this, who's part of a support group, to come and talk to the woman and reassure them, let them see what the scar looks like on her so she can kind of wrap her brain around the fact that I'm going to have a scar like that. The more prepared a woman is psychologically, the better they do post-op. The priority nursing interventions are to reduce anxiety and provide information to increase the patient's knowledge about what to expect. Include the spouse or the partner and all through these phases, because that the more support the patient has, the better they're going to do. Review the type of procedure planned. Ask her, what is it that that the surgeon's going to do? What have you agreed upon? Make sure she understands what she's agreeing to. Provide some post-op expectations, and these are just some of them. The need for that drainage tube. Where will the incision be? What type of mobility restrictions will I have, and for how long? How long am I going to be in the hospital? These women go home usually in the same day or the next day, which is kind of amazing in a lot of ways, but that's the way insurance is, really. There's a possibility of an adjuvant therapy, such as the chemo and the radiation, depending on what's left at the end. And then just general pre and post-op information as anyone needs for any surgical procedure. Post-op teaching would be to keep that affected arm elevated to promote lymphatic fluid return after removal of lymph nodes and channels. That you realize that when the lymph nodes are removed and the channels are removed, that the fluid is still going to be created by the lymphatic system, and now it has nowhere to go. So that it's going to try to accumulate in that area, and it will become, we're going to talk on the next slide about the effect of that. So they need to prevent that from happening by keeping that arm elevated for quite a while until that lymph system kind of adjusts. They should support their arm when they're up and walking. Don't let it dangle. Encourage her to look at her incision when she is ready. It is in her control as to when she's ready to look at that. We do not want to force that on her. Home care teaching. Older adults should not be sent home alone without a family member who can stay for a couple of days. It's going to be hard to move, hard to fix meals, hard to get around, hard to do your dressing change, any drain care that you might need to do. So they need help from someone who can be with them. They will start active range of motion exercises about a week after surgery, and it's important that that's stressed how important that is to prevent contractures due to immobility of the arm or the elbow. They need to learn infection prevention strategies and measures to avoid that lymphedema, injury, swelling of the affected arm. No lotions, ointments, no deodorant until the incision is completely healed, and elevate the arm as instructed based on the procedure that the surgeon did. And that would be up to the surgeon's orders as to how far to elevate that arm. Lymphedema is an abnormal accumulation of protein fluid in the subcutaneous tissue of the affected limb after a mastectomy. It is a commonly overlooked topic in teaching, but it is so important that it gets taught so it's prevented. Risk factors are injury or infection of the extremity, obesity, presence of extensive axillary disease, radiation therapy. Once lymphedema happens and develops, it can be very difficult to manage, and lifelong measures must be taken to prevent it. I know a woman I worked with, and she had to have her arm in it wasn't really an ace bandage, but it was a strong supportive wrap all the time. It was skin colored. It was on her whole arm, but it provided counter pressure to reduce that lymphedema. Teach these women to immediately report the symptoms, sensations of a heaviness in the arm, aching, fatigue, numbness, tingling, swelling in the affected arm or chest. Very important to prevent this problem, and we must teach to prevent it. Next on our list of exemplars is lung cancer. Lung cancer is the leading cause of cancer-related deaths worldwide. In North America, there are more deaths from lung cancer than from prostate, breast, and colon cancers combined. More than 228,000 cases per year are diagnosed, and more than 160,000 deaths occur per year from lung cancer. The overall 5-year survival rate is only 16%. And this is because most of them are diagnosed at a late stage after metastasis has already occurred. Only 15% of patients have small tumors and localized disease at the time of their diagnosis. Their 5-year survival rate is 52%. Despite advances in cancer therapies, the prognosis for lung cancer remains poor unless the tumor is removed completely by surgery. In those cases, treatment becomes palliative rather than cure. Most primary lung cancers come from cancer that started in the bronchial epithelium. These are called bronchogenic carcinomas. They are classified as either small cell lung cancers or non-small cell lung cancers. Metastasis occurs through the blood, lymph glands, and the blood vessels. Tumors in bronchial tubes can grow and obstruct the bronchus partially or completely. And tumors in other areas can grow so large that they compress and obstruct the airway or even put pressure on the heart muscle, resulting in cardiac tamponade. Staging of the disease is based on the TNM system, which is that primary tumor, number of regional lymph nodes, and distant metastasis. The etiology of lung cancer is repeated exposure to inhaled substances that cause chronic tissue irritation or inflammation. Of course, we all know the cigarette smoking is the biggie. It's responsible for 85% of all lung cancer deaths. The risk is related to the number of years the person has smoked and the number of packs of cigarettes that they smoke per day. Those are called pack years. Quitting smoking at any age reduces the risk, but the overall risk is higher in anyone who has smoked than in anyone who has never smoked. Secondhand smoke increases the risk over non-smokers who are minimally exposed to cigarette smoke. The assessment of these patients, there's a lot of things. I'm not going to mention all of them. You'll find them in the book, and I encourage you to look look in chapter 30 to find out detail on that. But and you're going to start on page 574. But check the history of risk factors. How long have they smoked? How many cigarettes per day? And then what are the symptomatologies that they may already be showing? This would be hoarseness of the voice, a cough, sputum. Is it bloody? Hemoptysis, bloody sputum, shortness of breath. Do they have a change in their endurance? Do they notice that they get tired more easily? Do a thorough pulmonary assessment. And bone pain or fractures, as skeletal bone mass will decrease in patients who have cancer, and so they may have bone pain or fracture easily. Fatigue, weight loss, anorexia, dysphagia, nausea, vomiting, these are all late signs. So if they come to you and they've lost weight and they're fatigued and not eating, they're well along the way to the end stage. There's something called superior vena cava syndrome and cardiac tamponade. These are two syndromes, two things that happen because of the cancer mass impinging on that space. If it gets large enough where it pushes on the heart rhythm will get off. They'll have cardiac tamponade. If it's impinging and encroaching on the vena cava, they get vena cava syndrome. So you need to do a really good heart assessment. Confusion, personality changes, that's evidence of oxygenation issues and perhaps metastasis to the brain. Bowel and bladder tone function changes due to if the cancer has spread to the spine. They're going to notice problems and changes in that. And then, of course, the psychosocial. Some of them will be probably many will be dealing with feelings of guilt, perhaps, because they basically did this to themselves, okay? If they're smoking, they didn't quit, it's their own fault. And so that you have to help them. We have to be non-judgmental about that and help them through that and pass the guilt and self-blame and on to what can we do to have the best quality of life from here on out. Diagnosis of lung cancer cytologic testing of early morning sputum. It's not always very useful. Really, it's going to be through a chest x-ray and then perhaps thoracoscopy to visualize. I think a frequent pattern of diagnosing, especially for a non-smoker, would be a chronic cough that just doesn't go away. So they go get their chest x-ray and they find a tumor. I think that's probably a pretty typical scenario. Interventions are aimed at curing the disease, increasing survival time, and or enhancing the quality of life depending on what stage of lung cancer they are in. The non-surgical interventions would be chemo. It's often the treatment of choice. There's something, this is actually kind of cool, photodynamic therapy. I had never heard of this myself, and it was quite fascinating. It's used to remove small bronchial tumors. The patient is injected with an agent that sensitizes the cells to light. And this drug enters all the cells, but it leaves the normal cells faster than it leaves the cancer cells. So they are injected, and then 48 to 72 hours later, most of the drug will have collected in high concentrations in just the cancer cells. So then they use a laser light to focus on the tumor. The laser light this is so cool. The laser light activates a chemical reaction within those cells that retain the sensitizing drug that induces irreversible cell damage. Some of these cells die and slough immediately. Others continue to slough for several days. So I think that's just pretty cool, and hopefully they'll be able to do more of that type of treatment. Now, realize these patients will stay in the ICU for close monitoring of airway management because that's going to cause inflammation and swelling when there's been some damage and irritation of the tissue in there. So they have to be watched closely for airway management. The surgical management of lung cancer is the main treatment for stage 1 and stage 2 non-small cell carcinomas. The total tumor removal may result in a cure, and that's of course what we hope for. Lobectomy or pneumonectomy are also options. A lobectomy if it's cancer is limited to just one lobe, or the whole lung removal. Pneumonectomy if it's not confined to one lobe. Pain management post-op is utmost priority. In a lobectomy, they're often able to do that under just three small incisions to work through and pull the lobe out through one of those small 3 incisions. And interestingly, they would wrap that tumor in a little bag before they pull it out through the little hole, so they don't have what's called seeding, seeding, seeding of the cancer cells back into the lung as it falls out through the little incision. But the pneumonectomy are usually done, are not able to be done with those 3 small incisions. So the pneumonectomy pain is intense in these patients unless that minimally invasive technique using 3 small incisions is used. Respiratory management is prime priority. These patients will be mechanically ventilated for a period of time. And then the pneumonectomy care, realize as they remove a lung, there's a pleural cavity now that is an empty space. So they may have a chest tube for a day. Not for very long though, but so that is something to realize, that these patients have to kind of adapt to that. And that's going to take a little time before that space becomes, you know, normalized. Pneumonectomy care. Oh, I just talked about that. Anyway, sorry. It is late. It's like 1 in the morning. So anyway, almost done here. Palliative care, that's if they're beyond cure, treatment. We just need to keep them comfortable. Make sure they feel safe as they deal with this. Oxygen therapy is vital, obviously. Drug therapy can be used to decrease bronchospasms, inflammation, edema. Mucolytics may be used to deal with thick mucus that's produced. Antibiotics if they are getting signs of infection. Even in palliative care, they might use radiation, and that's to relieve hemoptysis or obstruction of the bronchi and vena cava. Thoracentesis to treat the pleural effusion may be done, draining the fluid off. It may have to be done more than once. Dyspnea management, keep them in semi-Fowler's position, provide oxygen, morphine to help with the panic feeling of not being able to breathe. Pain management, again, and get hospice involved. I can speak from personal experience that hospice is just, they won me over big time when I went through what I went through with my dad. So they know what they're doing. Bring them on board. Now we're going to talk about colorectal cancer. The colon and rectum make up the large bowel. 2/3 of the tumors occur in the rectosigmoid region of the bowel, and most of them are adenocarcinomas, or tumors that arise from glandular epithelial tissue. Cancer in this area develops due to the loss of those suppressor genes. Remember that from the cancer development, those suppressor genes just don't work. They're lost, and then activation of oncogenes, and those oncogenes are what stimulates those cyclines. The cyclines are what causes cell growth. So the activation of those oncogenes alter mucosal cell division, and that combination allows colorectal cancer to develop. This increased proliferation of that mucosa is what causes polyps that can become malignant tumors. This is a good picture schematic of how the incidence and frequency of cancer in the various parts of the large intestine. You see here on the ascending colon, about 22% occur in that area. 11% occur in this transverse colon, 6% occur in the descending colon, and 25% of them occur in the sigmoid area. A third of them, practically 30%, are in the rectum. Metastasis of colorectal cancer occurs because it may spread locally into the 4 layers of the bowel wall and into the nearby organs. So it just takes over, that party gone wild, spreading out, taking over nearby houses in the neighborhood. The circulatory system is accessed directly from the tumor through blood vessels in the bowel or lymphatic system, so that can spread it very quickly. The liver is the most common site of metastasis, followed by lungs, brain, bones, and the adrenal glands. Those are also targets. Peritoneal seeding during surgical resection can occur, and that's when cancer cells break off from the tumor as it's being removed, and these little cancer cells will just fall back into the area that you're trying to get it out of, and then it seeds and starts to grow again. So special techniques are used to prevent this seeding and losing of cancer tissues. And we mentioned, I'm trying to think which cancer it was, but I was telling you about how they're bagged. They put a little baggie around the cancer so the seeding will not occur into the abdominal area, but rather it would just hopefully stay in the bag. Complications of metastasis are going to be bowel obstruction or perforation, which leads to peritonitis. They might have abscess formation, fistula formation that goes into the bladder or vagina. And the cancers, of course, may invade blood vessels and cause frank bleeding. All right, I hope I can say this. I had to practice this one. Etiology of colorectal cancer. The major risk factors are on this slide and the next slide, and the first one being over age 50. It's more of an elderly person disease. There is a genetic predisposition possibility. If there's a personal or family history of cancer, and get ready, I'm going to try this. If there's a family history of what is called adenomatous polyposis. I think I said it right. It's abbreviated FAP, and that's basically adenoma type polyps in colons that are not cancerous, perhaps other family members, but because of the fact that these are adenoma carcinomas and polyps generate them, that's why this FAP, I'm not going to say it again. You can say it. FAP is a risk factor. Crohn's disease, it's a chronic irritation of the bowel, ulcerative colitis as well. That chronic irritation type stuff will irritate those normal cells, healthy cells, and cause them to be less healthy, and they are at risk of developing into that syndrome of overgrowth and suppressor genes not working. HPV, the human papillomavirus, is a growing concern. They're starting to get cancers that have that as its basis too. We've spoken about that in relation to cervical cancer, I believe, when we were in the OB, but if we didn't, HPV is the precursor. Yeah, we talked about it in vaccines, I remember now. The precursor for potential cervical cancers, but it can also be a cancer in the colorectal area. Primarily the rectal. Other risk factors are long-term smoking. Think of teaching now. I want you to think of the teaching. These are things we can help them change. Long-term smoking, obesity, physical inactivity, heavy alcohol consumption if they're on high-fat diets, or diets that have large amounts of refined carbohydrates that lack fiber. A lack of fiber decreases the bowel transit time, and again, that causes a potential for irritation in the bowel and cancer development. The third, colorectal cancer is the third most common cause of cancer death in the United States. The overall incidence has decreased over the past 20 years, and they credit that due to these increased cancer screenings. So it's doing good, it's working. Education needs of people that have, of anybody, not people with cancer, but anybody. Teach about the need for the diagnostic screening. If they are at high risk due to some of those genetic factors we mentioned on the other slide, then they need their colonoscopy at age 40. If they're at normal risk, then we start doing colonoscopies at age 50. Fetal occult blood testing and colonoscopy should be done every 10 years. And some places will do the fetal occult blood testing yearly. It's just it's easy to do. It's not very expensive. Patients can do it at home, send it into the office, and the lab reads it. So it's pretty easy. So some places may offer to do that yearly, especially in the male population. And then there are double contrast barium enemas that could be done every 5 years. But primarily it's going to be your colonoscopies. We also want to teach our patients about dietary habits to improve our health, and that's to modify as needed to decrease the fat, decrease refined carbohydrates, and decrease in low fiber foods. We want to encourage baked or broiled foods, especially those high in fiber and low in animal fat. And the really good vegetables, broccoli, cabbage, cauliflower, and sprouts will help protect the intestinal mucosa from colon cancer. We also want to teach those modifiable behaviors such as smoking, excessive alcohol consumption, and physical activity. Those are things we can help them improve upon and decrease their risk. When we're doing an assessment on a patient who has concern about this, the subjective data we want to gather will be those major risk factors that we just talked about. Also, what is the patient's participation in age-specific cancer screening guidelines? Are they being proactive with healthcare? Do they drink? Do they smoke? What is their usual physical activity level? Basically, all those risk factors, we want to see if they have them. Fatigue, these would be symptoms of perhaps already having cancer, the fatigue, abdominal fullness, vague abdominal pain, unintentional weight loss, any changes in the bowel habit. This is very specific, and they would notice perhaps constipation, unable to pass stool, change in the shape of the stool, evidence of blood in the stool. Now, all that is the subjective data, much of the subjective data you want to obtain. The objective data that we would need to obtain would be, of course, visualizing for rectal bleeding. The provider would probably do a digital exam and see if there was blood on the glove. Notice the very last point that I put on here is that fecal occult blood screenings should not be done with that digitally obtained specimen, because this digital exam itself may cause some tissue bleeding, tissue trauma. So we don't want to count on that specimen. It should be an easily obtained specimen the patient would get from home without manipulation. If a patient has anemia, so we'd want to do a CBC, check the H&H levels. If their blood is low, we've got to find out where they're losing blood. You know, if they're a female, we would check into, of course, bleeding, normal menstrual bleeding, or postmenopausal bleeding. But otherwise, if we've ruled that out, we need to consider rectal and GI bleed somewhere. Do an abdominal exam. This is what you guys will want to practice doing, is palpating and listening. You want to palpate for distension and visualize for distension. Palpate for masses anywhere. Are there visible peristaltic waves? It's almost like a little ocean waves going through there. And listen for the absence or tinkling, any bowel sounds if they're absent, or if you're hearing tinkling of bowel sounds, that can indicate the presence of an obstruction if you hear tinkling. Fecal occult blood tests can have false positives, and so the patient needs to be told to avoid aspirin, vitamin C, and red meat for 48 hours prior to doing their fecal occult blood test. I've included this information because I found it interesting, number one, and number two, it was going to remind me to clarify information provided on the prostate exam, prostate cancer and BPH slide that Dr. Barber did. So first we'll talk about this one. It's called a carcinoembryonic antigen, or CEA, and it is elevated in many people with colorectal cancer. And this CEA is often used to monitor the effectiveness of treatment and to identify disease reoccurrence. So it's not necessarily a screening tool so much as a monitoring effectiveness and reoccurrence tool. And one of the students had a great question asking about the use of the PSA in prostate cancer. Dr. Barber had talked about that, and I did talk to her to clarify because she is the expert. And that PSA level is not a screening tool for prostate cancer. It is, just as this antigen marker is, it is used to monitor the effectiveness of treatment and to identify disease reoccurrence of prostate cancer. The diagnostic tool, shall we say, for prostate hypertrophy, whether it be benign or cancerous, is the digital rectal exam. That is how that enlarged prostate is found. So just that was a clarification of the prostate cancer information to make sure you understood the use of the PSA marker. Sigmoidoscopy is a visualization of the lower colon, and during the procedure, polyps can not only be visualized but also removed and biopsied. Colonoscopy is the definitive test for the diagnosis of colorectal cancer. That is how it is diagnosed. It provides views of the entire large bowel from the rectum to the ileocecal valve, and polyps, again, can be visualized and biopsied. The treatment goal: to remove the entire tumor or as much of it as possible so that we can prevent or slow metastatic spread of the disease. Radiation treatment is effective in providing local or regional control of the disease, but it does not improve the overall survival rates in colon cancer. It's often used to control pain, hemorrhage, bowel obstruction, or metastasis to the lung in advanced disease. Radiation treatment is almost always a part of treatment for rectal cancer. Chemotherapy is recommended after the primary surgery for patients with stage 2 or stage 3 cancer. We'll go more into detail on that with chemotherapy. The most common surgeries for this are the colon resection, a colectomy, and an abdominal perineal resection, depending on where the tumor is located. The colon resection will be removal of the tumor and regional lymph nodes. Of course, the goal, as it is with any tumor removal, is to remove the entire tumor out to where you have healthy borders. And that we have lymph nodes that are benign. So those lymph nodes would be checked. Colectomy is the removal of the colon with a colostomy to allow stool to come out through the colostomy. That colostomy may be temporary or it may be permanent depending on the extensiveness of the affected colon. Ideally, it would be done as a temporary measure to divert stool while the healing happened, and then it would be re-anastomosed once everything healed and was fine. But sometimes they're permanent, and going in, they don't always know, okay? The abdominal perineal, or AP resection, is performed when rectal tumors are present. The sigmoid colon, rectum, and anus are all removed through the combined abdominal and perineal incisions. So realize they're going to have incisions on their abdomen and also on their bottom in the perineal area. More about that colostomy. The surgeon may not know if a colostomy will be needed or not prior to surgery, so the patient needs to be informed of the possibility. It should not be something that's brand new, never heard of prior to him waking up in the recovery room. He needs to have that awareness. The surgeon will consult with the wound care nurse to determine optimal placement of that stoma. And he or she would be calling that wound care nurse in because that is the expert on knowing where the stoma will be less interfering with undergarments or prosthetics or patient activities. So they call that wound care nurse in. He or she would be marking the abdomen where the stoma would best be, and that's the surgeon's goal. There are 4 types of colostomies. There's the ascending colostomy, a descending colostomy, a sigmoid colostomy, and then that transverse colostomy, which is called a double barrel. Those are rare, and we're going to look at those on this page. You see the ascending colostomy is, let me see if I can get my marker. Okay, I get to play cologram. Okay, ascending colostomy is right here, and this involves very little of the bowel. The stool made here is very mucoid and liquid, so that's kind of that. This is the descending colostomy. It's done over here. I'm not very good at drawing that circle. Anyway, so that's on the way closer to the exit area. The sigmoid colostomy is the one that is absolutely closest to the exit area, and that's done for rectal tumors. And then this transverse or double barrel, you see the 2 sides here. There's one and there's one. It's often used, as it says here, in emergencies as intestinal obstruction or perforation because it can be created quickly. Just get the problem out of there, okay, or fixed if it's a perforation. There are 2 stomas, the proximal one, which is closest to the small intestine. So this one here will drain the feces. This one drains mucus. Otherwise, it doesn't do a whole lot. There's just mucus there. Colostomy management. The patient may return from surgery with a clear ostomy pouch already on, or he or she may have just a petroleum type gauze dressing covering to keep it moist, and over top of that would be a dry sterile gauze. The Wound Care Association recommends placing that pouch on as soon as possible, and it's called the appliance is how it's referred to. The pouch allows more convenient and acceptable collection of stool than a dressing does, and the colostomy should start functioning in about 2 to 3 days. Once that starts functioning, the patients will be taught how to empty it and how often, and when to just drain or when to actually change the pouch. The pouch should be emptied when it's 1/3 to 1/2 full of stool. It does not need to be completely switched out every time, but it just emptied out, and it will be completely changed out once the adherence to the skin starts to become less effective. It starts getting, it's not sticky on the skin very well, then they need to change the actual pouch. And everybody's different on how long a pouch can last. Some will last a week. Some have to change them twice a week. Again, that's very patient independent or dependent. What to expect? And these are things that you will want to also teach your patient. Right now I'm teaching you. A healthy stoma is reddish pink and moist. It should look kind of like, the inside of your lips, maybe kind of your mucous membranes of your mouth. It should be protruding about 3/4 of an inch from the abdominal wall. So it's going to pop up a little bit. Just so you know what type of stool one could expect. Its stool is liquid immediately post-op, but becomes more solid depending on the location in the colon. The more liquid the stool is, the greater the risk of causing skin irritation, if you can imagine that. It's more liquid when it comes from that ascending colon, as I mentioned. As it gets up in the transverse colon, it becomes more pasty, so it's not going to be as fluidy hitting on the skin. And then in the descending colon, it's going to be even more solid. So you're going to have minimal skin irritation, or less, I should say. Of the 3, it would be the descending colon that's less at risk for that, because the stool's not going to be sitting, be wet on that skin. Hopefully it's not on the skin at all, because we do use protective barriers. You will be learning about that in skills, I believe, and hopefully some of this will come back to you when you're learning that. With an AP resection, that's a little bit different than the stomas on the abdomen. The serosanguinous drainage from a perineal wound may be observed for 1 to 2 months. It might take 6 to 8 months to have complete healing. It's a greater source of discomfort than the abdominal incision in ostomy because they're sitting on it. It's on their bottom, okay? And rectal pain and itching may occur. And there's creams we can use to help them with that. Realize in the midst of all of us trying to get used to doing stoma care that our patients are going through a grieving process, and their families are as well. This is very life-changing in so many ways. No one expects to have to poop out their abdomen, right? I mean, you don't go into life thinking that's what's going to happen. So it's very, very stressful. Our interventions need to be geared toward helping the patient and the family express their feelings, whether they're grieving or fear. Help them develop coping skills. Help them to know it's going to be okay, that right now it's scary, but each day it's going to get less scary, and eventually it will be something that you just accept as part of life. But right now we realize that is scary. Families, this is weird, this is definitely an ethical thing, but families may request that patients not be informed about the diagnosis of cancer, particularly if the patient is older. I read that in our book. I'm not sure. It didn't make any comment other than that. And of course, there's an ethical thing. You better believe I'm going to talk to my patient. He's my patient. Okay? He's my patient. He or she is my patient. That's the person in charge of what I tell them. That's how I feel about it. So you figure out how you feel about it. If a colostomy is planned, we can begin to teach that patient and the family pre-op regarding what to expect afterwards, and a little bit about the care of it, really general at this point. Just say, just show them a picture of a stoma and let them know very generally that you'll have a bag. It will help collect the stool, and we will teach you how to empty that bag and take care of it. Pretty much that's all I would teach prior. Post-op teaching would be done as they get out of recovery. I would encourage the patient to look at the stoma and to touch it, eventually participate in colostomy care. This is where we want to do what I call layering of education. You do not want to throw all of this on the patient at one time. This is not a one visit type thing. This is going to take several visits to building acceptance and building confidence in taking care of it. So do not expect to get everything done in one visit. Not going to happen. So if you can get them to look at it and just even put their finger to touch it, that's a great step, okay? And then eventually we have them watch us do colostomy care. And we may have the family member that he decides, I say he, I don't know why, because women can get them too, but that check the family member that person has designated as someone that he or she wants to learn about it, because it's nice to have that second person at home to help. Once they're able to participate in their own care, this helps restore their independence and gives them more of a sense of self-control again, and it improves their self-esteem again, which is going to be badly injured. Like I said, nobody expects to poop out of their abdomen. And help the patient identify lifestyle modifications that will be needed. Interestingly, there is a young girl, I don't know her personally, I just saw her online, but she has she is a stoma patient. She's young and maybe in her 20s, maybe early, she's young, okay? And she's created stoma bags that are cute. She goes on the beach, she wears her bikini, she has her cute stoma bag on, and she has embraced it to the sense of, this is part of who I am and I'm going to be okay with it. And then I don't know if she's selling these or what, but it's pretty cool that she's made really cute and fun stoma bags. So that's the sort of acceptance that we would strive for on these patients. Not everyone will get that far, but boy, if we do, we've helped her or him go a long way on dealing with this. For colostomy care, it's important to teach the family and the patient about the normal appearance. As I said, it should be pink and moist. It should look like the inside of your lips, perhaps. We want to teach them about the signs and symptoms of complications, specifically skin breakdown. What would it look like if that skin's getting real irritated? How about it really pale? If the stoma is getting too pale and looking, it could be that there's not circulation coming to it for some reason. If it's all of a sudden not draining right, not draining its normal amount, they'd want to go and be seen and find out what's going on. Measuring the stoma, that's important because we have to know how big to make the hole in the stoma bag, because those holes, everybody's stoma is different, okay? It's a different size for everybody. So each person will have to make their own little template of how big the hole needs to be for the stoma bag. And the ideal is to make it not just as big as the stoma, but another 1/4 of an inch bigger. So that there's room for that stoma to expand when it excretes stool, because it does. It will expand as it contracts, and it needs that extra space to expand. Otherwise, you will cut off circulation, and it will turn pale, and it will become necrotic. So we don't want that to happen. So important to teach them, and you'll do this in skills lab, of making that hole a 1/4 of an inch bigger than what the actual stoma size is. Once they have that template made, they can just use it unless they gain a lot of weight, lose a lot of weight, big changes like that. But otherwise, once the stoma is there, the size is there, it's the same size unless weight changes. We would teach them the choice, use, care, and application of the appropriate appliance to cover the stoma, help them get comfortable with it. Measures to protect the skin adjacent to the stoma. There are ointments that we can use that still allow the appliance to stick to the skin. It's like you can't put lubricant on because the appliance won't stick, and therefore it will leak. But there are measures that we can use to protect the skin adjacent to the stoma that also allow stickiness to happen. Nutrition changes. Now, stoma patients can eat anything they want. They are not on restriction, except for what they don't like the side effect of. So some people will have severe gas produced by certain foods, or odors produced by certain foods that they don't like it. So they will learn to identify what to avoid and what they can get away with, okay? They do have things that they can put, that's a bad medical term, but they do have stuff isn't any better, but items that can go in the bag to help control the odor and to help control the gas produced a little bit. So there are things that can happen that can be used to minimize that, but the main change is going to be through nutrition. We also need to talk to them about resumption of normal activities, including work, travel, and sexual intercourse. And I would imagine that work and travel is a lot easier to talk about than the sexual intercourse, but that one would involve the partner. I definitely would want the partner involved in that conversation. Again, it's a very awkward situation for patients that are newly getting used to these stomas, and they require our patience, our understanding, our compassion, and our information and reassurance. And finally, just some resources for stoma patients if you ever needed to have access to them. The United Ostomy Associations of America, they come out with a quarterly magazine called Ostomy Quarterly, which could be useful for patients. And then the American Cancer Society, they can actually help provide supplies, home care services, transportation, very useful organization. Also, there probably in somewhere are stoma clubs where they can meet with other patients, or at least meet one other patient that is an experienced stoma wearer, and that person can perhaps help them deal with some of the transition. And that's it for our colorectal. Our final exemplar for cancer are these two: acute lymphocytic leukemia and non-Hodgkin's lymphoma. So we're going to start with leukemia. Leukemia is basically a cancer with an uncontrolled production of immature white blood cells. These are called blast cells. Those are the immature cells that never get into maturity. And of course, they're made in the bone marrow where white blood cells are made, but they don't get out of the immature stage. The bone marrow then becomes overcrowded with immature and non-functional cells, and the production of normal blood cells is therefore greatly decreased. This leukemia, this problem may be acute, which is sudden onset, or chronic, which is slow onset. And leukemias are classified by cell type. They can be either lymphocytic or lymphoblastic, which means they come from lymphoid pathways, or they can be myelocytic or myelogenous, which come from the myeloid pathways. Cancer most often occurs in the stem cells or early precursor leukocyte cells with leukemia. This causes an excessive growth of a specific type of an immature leukocyte. Just think of really immature white blood cells. That's what leukemia is. In some chronic leukemias, the cancerous cells may be more mature, but they're still abnormal. Their excessive production in the bone marrow stops normal bone marrow production, and this leads to anemia, thrombocytopenia, and leukopenia. So think of how this is going to affect your patient. They have anemia, they have low platelets, and they have low white count. Without treatment, the patient will die of infection or hemorrhage. The cause of leukemia is unknown. There are genetic and environmental factors that may be involved in development. But why does this person exposed to carcinogens not get leukemia and this one does? That's an unknown. It may have to do with those genetic predispositions that we talked about earlier in the semester, the genomics. The basic problem involves damage to genes that control the cell growth. Remember, we're talking about this every time we talk about cancer. Those genes are abnormally affecting cell growth, and this damage changes cells from a normal to a malignant state. Bone marrow analysis shows that there are abnormal chromosomes about 50% of the time with leukemic patients. The possible risk factors are a big list here, which I'll go through. It's radiation, viral infections, exposure to chemicals and drugs, disorders such as myelodysplastic syndrome of Fanconi's anemia. I have no idea. Don't ask me. I'm not going to ask you. Don't ask me. If you want to know, I will be glad to look it up and find it for you, but you can do the same thing. Anyway, genetic factors can be a causation. Immunologic factors, of course, environmental factors, and an interaction of all of the above. There is also an increased incidence of leukemia in Down syndrome, Bloom syndrome, and Klinefelter syndrome, and Fanconi's anemia. There he is again. So there's a genetic, a chromosomal link as well. Leukemia accounts for 2% of all new cases of cancer and 4% of all deaths from cancer. There are about 49,000 new cases every year in the United States. It's classified into 4 different types based on the cell type affected and how fast the disease progresses. The most common one is acute myelogenous leukemia, and it's weird. Interesting, I should say, because the exemplar we were given to talk about was acute lymphocytic leukemia, but that's only 10% of the leukemia. So I don't know. I just do what I'm told, okay? Acute myelogenous leukemia is the most common one, followed by acute promyelocytic leukemia, and then the acute lymphocytic leukemia, chronic myelogenous leukemia, and then chronic lymphocytic leukemia. You don't have to memorize those. They're just different types. And 4 different types, and I've listed 5 here. I don't know. I did what the book told me to do. Okay, I just took a minute to look at the referencing again about the leukemias. The table 40-2 on page 807 lists 5 types of leukemia, but in the narrative it mentions 4 types. It's not really important to me, but do know that there are 5 types of these leukemias, not 4. And I'm not sure what the disconnect is, but I'm not worried about it, so don't you worry about it, okay? I just wanted to double check that though. Anyway, so the assessment, we have to get into the subjective. What do we want to know about these patients? What would you want to know about a patient who's at risk for infection, hemorrhage, etc.? Let's ask about exposures to risk factors and the related genetic factors. Age is important because the risk for adult onset leukemia increases with age. Let's ask about their occupation and their hobbies. Are they doing something that's continually or kind of chronically exposing them to carcinogens that could kick this leukemia into play? What are their previous illnesses and medical history, exposure to the radiation or drugs that increase the risk? What is the frequency and severity of infections during the past 6 months? And these can be as simple as the cold, the flu. What have they dealt with? Some people deal with infections frequently, others never get sick. We need to know that. And talking about the bleeding problems, let's evaluate them, specifically asking them, do you bruise easily? Do you have nosebleeds? When you brush your teeth, do your gums bleed? Is your menstrual flow heavier than normal? Rectal bleeding? Do you have hematuria? All these are important in evaluating that platelet issue. Let's also ask them about weakness or fatigue, which could indicate anemia. Get an activity. Look at the bottom, a 24-hour activity history, I think is very important for these patients. What has your last 24 hours been like? How about headaches, behavior changes? Are you having a decrease in alertness? Again, that fatigue pops in. You get sleepy, falling asleep when you normally wouldn't. Decreased attention span. I'm thinking about all of our meetings that we have at the School of Nursing, and I'm thinking, oh my God, I have leukemia. Sorry. I had to get back on track here, okay, because we are meeting so long lately. So many meetings, too many meetings. But that's not leukemia. That's meeting disorder. Okay, sorry. I digressed. Okay, decreased attention span. Again, you're dealing with maybe I have leukemia. I have a decreased attention span here. Sorry. It is 11:30 at night. No, almost midnight. So bear with me, people. We'll get there. Muscle weakness, loss of appetite, or weight loss. All those could be symptoms of a lot of things, but we're talking in terms of leukemia right now. The objective data we want to assess would be cardiovascular. Due to the reduced perfusion and gas exchange, due to the anemia, what are the changes you would expect in the cardiovascular system? I'm thinking increased pulse rate, right? Maybe look at your nail beds, look for signs of pallor, cyanosis. The respiratory system, again, reduced gas exchange from anemia and infection. What would you expect there? Perhaps an increase in respiratory rate. Back to the cyanosis, okay? Listen to those lung sounds. Skin changes, pallor, coolness, petechiae, indicating potential bleeding problems. What are the intestinal changes? Are there any? They do have an increased bleeding tendency. So are their stools darker than normal? Do they have fatigue? Shows up again. How about weight loss, nausea, anorexia? Does a stool show occult blood? Do they actually see blood in the stool? That's what occult means. You don't need the lab. You can see it with your eye. Constipation, reduced bowel sounds, enlargement of the liver or spleen, abdominal tenderness. All those are evaluation things that you need to do. Now, constipation is on here, I noticed after I typed it out from the book, but that's a subjective symptom. It's in the objective. It's okay, ask about it, but you're going to listen to bowel sounds and do a abdominal exam. How about the central nervous system? Headaches, papilledema, headaches, yes, those are subjective, but seizures and coma. And then the miscellaneous, again, this is subjective, but bone and joint tenderness. That's kind of classic for leukemia, bone and joint tenderness, very classic for leukemia. Of course, the psychosocial is just as important as anything else. They're very fearful. Can you imagine if someone tells you they think you have leukemia? What is your first impression about leukemia? Who do you know that's had leukemia? The patient also will be going through those emotional reactions. Who do they know that's had leukemia, if anybody? They're going to be very anxious. They're going to not know what to expect. And it's important to try to educate them as best we can. These patients will be hospitalized a long time because of that risk of infection. Okay, we need to keep them in as sterile of an environment as possible, because the goal is to wipe out their immune system and then build it back up in a healthy manner. So in that process, they are at extreme risk for severe infection. So during those several weeks they're in an isolated room, can you imagine the boredom, the loneliness, the isolation, and then the financial worry? People, not people plural, but they can have a visitor or two, but always super gowned up and ready, just very, very careful to not infect these patients. So it's not an easy journey that they are on. If they have children, the children won't be able to go in and see their mama or their daddy. So yeah, that's another stress. Let's look at the laboratory expectations for leukemia. We're going to have a decrease in that hemoglobin and hematocrit and a decrease in the platelets. The white count will be abnormal. It actually may be low, normal, or elevated, but a high white blood count is mostly made of those immature blastocyst cells, and those patients have a much poorer prognosis. The definitive test for leukemia is actually examining the cells obtained from bone marrow aspiration and biopsy. It's the only way to really definitively diagnose it. The bone marrow is full of leukemic blast face cells. These are those immature cells that are dividing, but they don't, it's like taking a toddler and telling them to clean the kitchen. They can't do it. My analogies are weird and it's late. The proteins, this is another interesting thing. We've talked about how the markers in the prostate and in the colorectal cancer are not diagnostic. They're markers evaluating disease progression or treatment, if the treatment's effective. In this case, the proteins or antigens on the surfaces of the leukemic cells are markers that help diagnose the type of leukemia. So they do aid in diagnosis in leukemia, and they may indicate prognosis. So they're a little bit different on this type of cancer, okay? Just kind of keep that separate in your head. The blood clotting times and factors are usually abnormal, we've mentioned. Whole blood clotting time is prolonged, as is the activated partial thrombin, prothrombin time. So all those it takes longer to blood clot. It just takes longer to clot the blood. Chromosomal analysis of the leukemic cells may identify marker chromosomes to help diagnose the type of cancer of leukemia, and predict the prognosis and determine the therapy effectiveness. I don't know why they name stuff like they do, but the Philadelphia chromosome is one that's specific to the acute lymphocytic leukemia, and the translocated chromosome inhibits cell apoptosis. Now remember the word apoptosis? That's the one that tells the cell to stop growing. Remember, it says die, cell die. Well, this translocated chromosome, the Philadelphia chromosome, inhibits that, so the cells are never told to die. So they keep growing. These bad cells keep growing, and it of course affects the DNA repair as well. The desired outcome we have, big one, prevent infection. If we can prevent infection, we're really we're getting down the path really well. Infection is a major cause of death in the patient with leukemia. And so it is vital that we not only use proper hand washing before we even go in the room, but that we use the protective gear, that we're the hat, the gown, the mask, the gloves, to protect the patient from us. This is when we put that protective gown and glove stuff on to protect the patient. Any visitor going in the room will also do the same, dress up and hand washing the whole bit. Infection can occur through both auto-contamination and cross-contamination. And auto-contamination is that which the patient unfortunately does to self. And cross-contamination is what others bring into the room. With the auto-contamination, the most common sources are through skin, respiratory tract, and intestinal tract. It is so vital that our patients do their own proper hand washing, especially after going to the bathroom. Make sure their skin is intact to prevent any risk of wound infection, and that they maintain a clear respiratory tract. Drug therapy has 3 distinctive phases. There's the induction phase, the consolidation phase, and maintenance. Induction is, I would say, the scariest stage. The purpose during induction is to achieve a rapid, complete remission of all manifestations of the disease. This therapy results in severe bone marrow suppression, which will result in neutropenia, and this makes the patient at even more risk of infection. Basically, we're wiping out everything in that patient's bone marrow, okay? Prolonged hospitalizations are common while the patient is neutropenic because it is the best way to have a controlled environment. Recovery of bone marrow function requires at least 2 to 3 weeks, during which infection is a life-threatening risk. So just imagine they are doing chemo, they're doing radiation, they're wiping out everything in this bone marrow. The goal to be to wipe out those crappy blastocyst cells that do nothing but make the patient sick. Once we bring them down to nothing, then we're going to help bring them back up to something. The consolidation phase, the intent in this phase is to cure the patient, and it may be a single course of chemo or a combination or repeated courses of chemo. And then the maintenance therapy for drugs may be prescribed for a month to years after successful induction and consolidation therapies. And the purpose of maintenance is to maintain that remission achieved through the induction and consolidation times. Prevent infection. How do we do that? Hand washing. Staff and visitors wear a mask if there's any signs of an upper respiratory infection. In fact, I'd say stay out of the room. Observe strict asepsis in all procedures. They should have a private room. The book says something about if, they may have a private room. What's this may stuff? They need a private room. They don't need anybody in the next bed over there with their visitors. No standing water, in other words, no flowers, which is kind of sad, but they could do, fake flowers. But anyway, no standing water, denture cups, or humidifiers, because bacteria grows in those warm, moist areas. They should be in a high efficiency particulate air filtration room to help keep that air as pure as possible. We nurses must do continual and ongoing assessment for any signs and symptoms of infection. Lab-wise, a daily CBC with a differential and white blood cell count. Every shift, very thorough shift assessment of lesions and mucosal breakdown, lungs, lung sounds, check for pneumonia, urine, look for if it's clear, is it cloudy, and vital signs should be done every 4 hours in these patients. How do we bring these people back up to a healthy bone marrow? That, of course, is essential to the treatment. You can't do that. You've just killed your patient. There's different methods to do that, and this one we're going to talk about is the hematopoietic stem cell transplant. This is bone marrow transplant. It is the standard treatment for patients with leukemia who have closely matched donor, who has a closely matched donor, and who is in temporary remission after induction treatment. Remember, we talked about the induction treatment. Let's get them in remission, and now we can put stem cells in there to try to get them into a healthy cell production. The bone marrow is the actual site of production of leukemic cells. We must be sure that all leukemic cells have been eradicated during that induction therapy. Therefore, before HSCT, additional chemo with or without total body irradiation is given to purge the marrow of leukemic cells. Can you see the concern and the risk of infection because of that? Bam, it's all gone. These treatments are lethal to the bone marrow, and without replacement of stem cells by transplantation, this patient's going to die. I mean, they don't have anything to do. They're going to die of infection or hemorrhage. After conditioning, new healthy stem cells are given to the patient, which go to the marrow and then begin the process of hematopoiesis, resulting in nice, normal, properly functioning blood cells, and ideally a permanent cure. And I will tell you, a physician I worked for when I first moved to Atlanta, Dr. Ehrlich, his son at the age of 17 had leukemia. And he went through all of this, and this 17-year-old, goodness sakes, let's see, now he moved here in 1992. He's still doing fine. He's fine to this day. 92, so 20, good Lord, 25 years later, he's doing good. So it will cure if it can be done properly. Cord blood harvesting. This involves obtaining stem cells from umbilical cord blood of newborns. This blood has a really high concentration of stem cells. They are doing so much with stem cell therapy that there could be a lot of miracle cures in the future. The conditioning regimen. First, patient undergoes a regimen which varies with the diagnosis and type of transplant to be received. This conditioning regimen serves two purposes. It's to wipe out the patient's own bone marrow, thus preparing him for optimal graft take, and then to give higher than normal doses of chemo and or radiotherapy to rid the person of cancer cells. It's usually a period of 5 to 10 days is required for this. It's only after this that you're going to have successful transplantation. There are side effects of a stem cell transplant: fever, hypertension. Often these patients are given Tylenol, hydrocortisone, and diphenhydramine to prevent some of these symptoms, given before the infusion. Antihypertensive and diuretics may be needed to treat fluid volume changes. We can work with that, okay? We can treat that. The transfused marrow cells will circulate briefly, and then the stem cells find their way to marrow-forming site of the patient's bones and establish residency there. And this is called engraftment. This is what we're looking for. This engraftment is the key to the whole transplantation process. The average time to engraftment for these cells is 14 days. For bone marrow, it's 21 days. Chimerism is monitored, and that's an interesting phenomenon, the presence of blood cells that are not of the patient's genetic profile. So once we see that chimerism has happened, then that patient's body has accepted these different non-leukemic blood cells as its own. It's a good thing. The biggest concern during this, of course, is that infection and poor clotting, and the complications are often severe and life-threatening. Interventions, platelets are decreased as a side effect of chemo, and they may be less than 10,000. Now, we talked in OB about epidural. Before an epidural can be given, those platelets need to be at least 100,000. So look at this 10,000 and you'd be like, whoa! So you know these patients are at an extreme risk for bleeding. Bleeding precautions are vital. We need to monitor lab values, and we need to help that patient conserve energy and reduce fatigue. These patients do go home before they're completely well. The home care is the same as is in hospital. We need to educate them how to prevent infection and minimize the bleeding risks. Teach them to assess for petechiae, avoid trauma and sharp objects. They should not be the ones cutting up things with knives. Apply pressure to wounds for 10 minutes. Report blood in the stool or urine or headaches that do not respond to acetaminophen. This severe fatigue will continue for a long time. They just need to be taught or need to learn to be patient. It's just going to take a while. Sleep when you need to sleep. It's okay. The expected outcomes are to remain free of infection and sepsis, to not experience episodes of bleeding, to be able to balance activity and rest, and to use energy conservation techniques. I'm sure by now all of you think you have leukemia because we're all tired. I understand that. All right, let's move into Hodgkin's lymphoma. Actually, non-Hodgkin's lymphoma is our exemplar, but you know what? I wanted to know what Hodgkin's lymphoma was, because if I'm going to learn about the non-Hodge, I want to know about the Hodge. Okay, so it's a real briefly. Hodgkin's lymphoma is a cancer that peaks in 2 different age groups, teens and young adults, and then we old people, adults in their 50s and 60s. The exact cause is unknown. It's possibly viral, Epstein-Barr, human T-cell leukemia or lymphoma, HIV, and chemical exposures. Potential, we don't really know. Hodgkin's lymphoma usually starts in a single lymph node and they spread very predictably from one group of nodes to another, and that is the main distinguishing factor between Hodgkin's and non-Hodgkin's. Hodgkin's is much more predictable. It contains a specific cancer cell type called the Reed-Sternberg cell, which I'm sure was discovered by someone named Reed and Sternberg. It is one of the most treatable types of cancer. Now we're going into non-Hodgkin's lymphoma. These are all lymphoid cancers that do not have that Reed-Sternberg cell, okay? It spreads through the lymphatic system, and it is not orderly. It is less orderly than the Hodgkin's. It doesn't have any rhyme nor reason. It can do this in one patient and go there in another, okay? There are about 70,000 new cases every year, and it's more common in men and older adults. The incidence is higher among patients with solid organ transplantation, immunosuppressive drug therapy, and HIV disease. So there's something to do with that, the immune system. Symptomatology for this is basically swollen lymph nodes. It is a painless swelling of the cervical, axillary, inguinal, and/or femoral nodes is most often seen. Diagnosis is made only after the biopsy of an involved lymph node. There is a classification system. It's based on the cytology. It's not a single disease, but rather a group of diseases. And it must be typed because management varies with that subtype. And bone marrow involvement is common. So that does it for the different exemplars of our cancer. I will do another PowerPoint on chemotherapy, so watch for that, and I hope this has helped you understand all these different exemplars.